And as I reflect on their journeys and stories, I sincerely hope that I do them justice. I also want to highlight as I start this presentation that context matters. I'm joining you here from Toronto, Canada, almost 21-hour journey away from Hope Exchange Medical Center. I highlight here a picture of sick kids on a beautiful spring day. However, the contrast between our institutions may grow as I share with you a picture from a couple of days ago from a snowstorm and negative 30-degree weather that we have here in Toronto. Our institutions may differ on a number of metrics in our size and our age. However, both are considered centers of excellence in their respective countries, offering advanced clinical care and specialized education. And importantly, as we celebrate today, translational research ideas and practices that are going to improve and revolutionize healthcare capacity for countless number of children and families. I recognize that context matters, and the information that I'm presenting comes from my own Canadian and North American context in which I was raised, I was trained, and I now practice. You, the clinicians, the researchers, the dignitaries, the policymakers, and the parents are the experts in your community, and I look forward to continuing to learn together from your experiences. So I understand we are also celebrating an anniversary of 12 successful months of the Survive to Thrive program. And as you'll hear from, and I've already heard from distinguished guests, doctors, parents, the Survive to Thrive program is the first of its kind in Ghana. It provides comprehensive support for mothers from preconception through pregnancy, childbirth, and the baby's first 1,000 days of life. The central philosophy of Survive to Thrive, that children should not only survive, but thrive, grow, develop well, flourish, and prosper, brings to mind the concept of resilience, such that when in face of adversity, children and families can do well. Now, admittedly, there's been some controversy over this word and this term, claiming it may have too much of an individualistic approach. It may be culturally laden and biased. And I've heard and learned concerns from parents themselves about the pressure from this label. However, others, and as I will reflect on, go beyond the individual approach and reflect how communities fostered in programs like Survive to Thrive can support young children in their families to prompt thriving and resilience. So today, in the time that I'll have with you, I want to reflect on 4 central ingredients that I think really embody the Survive to Thrive program in terms of the importance of promoting every child's potential, providing timely support, early detection, providing it within a socio-ecological framework that supports resilience. And knowing resilience doesn't come in an isolation. It comes through building relationships and supporting caregivers. Resilience is shaped from the earliest moments of life, beginning with preconception and continuing through the first 1,000 days. Early caregiving and maternal well-being and relational safety lay the foundation for lifelong brain and mental health. The Survive to Thrive program in Ghana exemplifies this principle by supporting mothers and infants from preconception to age 2. This approach aligns with developmental science, knowing that the earliest caregiving environments can have a profound and lifelong impact on outcomes across brain health, cognitive, emotional, and social domains. The Survive to Thrive program demonstrates how resilience can be cultivated even before birth and throughout childhood, providing a strong anchor point that connects the Ghanaian model to similar work across the globe. The Survive to Thrive programs, the mega clinics it offers, comprehensive assessments, including newborn screenings, hearing tests, physiotherapy, nutrition counseling. All of this provides a mechanism by which we can reduce the downstream impacts and improve developmental pathways. To tell you a little bit about Sick Kids where I am, we provide the highest level of care for the sickest babies in our province. Please note that Sick Kids is not a birthing center, but babies are brought to us in their initial hours to often receive life-saving treatments following respiratory issues, neurological concerns like neonatal strokes, sepsis, being born extremely preterm, and children needing life-saving surgeries. Like the Survive to Thrive program, our neonatal follow-up, parallels that and connects children to experts in the field at key intervals along the early days and months of their life. They then transition to my service, which offers older children, ages 4 to 18, more in-depth assessments of their cognitive and academic evaluations, and importantly, how medical conditions, understanding them, can affect and understand and promote brain development. As a neuropsychologist, I've worked with many different children who've been given life-changing diagnosis at the time of birth, children or even before, congenital heart disease, children born extremely preterm, pediatric stroke and neonatal stroke, epilepsy, and children with hypoxic ischemic encephalopathy. And as shown in this slide, there are countless number of risks associated with these children and their families' development. Yet, I've heard time and time again, children who've received the worst diagnosis, maybe they've been told very, very scary concerns about their baby. Parents have shared with me remembering our doctor couldn't give us what was going to happen. They couldn't give us a prognosis, but it was possible our son wouldn't walk, talk, or go through regular education. Another parent recounted to us, initially we were told the best case we take home a child with brain damage. The worst case is we do not bring him home at all. Yet, we've all had, as healthcare workers, the privilege of meeting these children, whether they be 4, 6, or 18 years of age, who come to our offices, walking, dancing, singing. These children and their families are shining examples of resilience and thriving, and have informed our ways of knowing and promoting the knowledge forward to other families. Linda Theron of the University of Pretoria has written extensively on resilience in children in sub-Saharan Africa, arguing it is not a single trait, but a complex, multidimensional process that can be shaped by a range of influences, relational, personal, structural, cultural, and spiritual. Emotional support, not just from parents, but the family and the broader community, play a critical role. These supports provide stability, encouragement, and a sense of belonging that helps our children along these pathways overcome challenges. And at its root, resilience is fundamentally relational. It's built and maintained through connections with others. Because resilience is rooted in relationships, we need to focus on community-based approaches like the Survive to Thrive program. One of the most cited work on socio-ecological systems is that of Urie Bronfenbrenner. And you may be familiar with this concentric circle in which the child is at the heart, but you surround it with its family, its community, its culture, its country, and its world. I personally love a quote that I try to embed in most of the presentations I do with learners in the importance of people surrounding that child with love. As Urie Bronfenbrenner shared, someone's got to be crazy about that kid. That's number one, first, last, and always. The Survive to Thrive program illustrates how resilience can grow across interacting systems by the interacting multiple layers of support. Each of these layers nicely onto socio-ecological models of resilience. It recognizes resilience in communities is deeply relational, grounded in kinship, spirituality, and collective caregiving. I love how the Survive to Thrive program honors and leverages cultural strengths and aligning with existing values and practices, WhatsApp groups, peer networks, and large community clinics that build relational resilience by fostering community, belonging, and mutual support. This approach recognizes and emphasizes resilience is not a solo sport. It is co-constructed in the relationships that we can foster. And by embedding cultural strengths into the model, Survive to Thrive demonstrates how relationships and collective caregiving can strengthen resilience and thriving for both children and families. And finally, the final core ingredient is the importance of the caregiver themselves. Caregiver mental health is one of the strongest predictors of thriving and resilient outcomes in children across the world, especially in those with early medical and developmental risk. The Survive to Thrive program responds to each of these realities by embedding caregiver supports, parent support groups, accessible health education, and those continuous touch points with clinicians that care. These supports strengthen parenting capacity, which in turn enhances our children's resilience. Research time and time again consistently shows that when parents feel supported and confident, our children experience improved development, emotional, and behavioral outcomes. All of this is aligned with the World Health's vision in promoting a framework for brain health optimization. You can see the echoes of the Survive to Thrive program across each of these determinants of brain health that we can promote across the life course, from promoting physical health, from supporting healthy environments that can be safe and secure, and promoting attachments through learning and social connection between parent and child. And above all, championing the access to the quality of services that the Hope Exchange is mentoring through this program. I'll take a moment to reflect on the power of the parent and the caregiver voices in our own work that has led to the same understanding, the power of community and through these types of program, connecting support needed for young children and families. In our early work, we heard how stressful it can be for a young parent to get the news and to take in the information about their child's medical condition. One parent recalled, "It's stressful. You're trying to take in so much information and some stuff you don't understand because you didn't study the brain." Clinicians have also emphasized how important it is in our early conversations with young parents and their children. One parent or one clinician poignantly shared with me, "When you discuss a child's outcome or diagnosis, if you do it poorly, those parents will never forgive you. But if you do it well, with sensitivity, humility, and care, they'll never forget you." Parents also reflected on the need to care for themselves and with the reality that sometimes in busy medical centers, sometimes it's only about the child and we don't take the time to focus on the person that has to take care of that child. And the reality that a lot of parents don't put themselves first, they don't think to take care of themselves. And clinicians struggling with ways of extending their support. Do we do enough here for this family? In our own work, we've also looked at alternative ways of looking at resilience and conceptualizations of how families thrive to really define it from the parent's perspective. And as shown here in one of our publications, it really hammers into the importance of considering thriving from multiple lenses, meeting and exceeding developmental milestones, walking, running, jumping, being happy and healthy, conceptualizing how just amazed parents can be in observing their child's development and they're on being able to support them in their learning progress throughout the early years. From a factors perspective from families, what they can do to optimize their child's resilience. Well, parents reflect that it is an innate. There is something about the child's personality that they bring to the equation, the determination we can see and foster in our young children. Parents acknowledging how much they feel they can give in those early days, the work at home to optimize their child's early development in speech, language, and motor skills. The connections to programs like Survive to Thrive. Early services really matter. And those touch points, the connections they can continue to have with their medical team are strong investments in long-term outcomes. And finally, I like to share this quote from a parent because it sticks with me every day. The importance that families need to embrace maybe their child's diagnosis, but understand it does not define the child's prognosis or the abilities long term. In our own community program, we have the Interact North virtual parenting intervention that I spoke with Dr. Adoma about, where we do virtual coaching sessions to promote positive, responsive parenting skills among these children and families in their community. We follow the World Health Organization's guidelines on parenting interventions that can enhance those key fundamental parent-child relationships. This includes how to help families build warm responsivity into their child's needs, to build positivity and consistent follow through, in which we realize there's a lot of unpredictability in these children's lives and stress that we can help families cope through that unpredictability. People laugh, but we chose a virtual program prior to the pandemic, and we've been privileged to be able to learn from an increasing diversity across our large province among families that would not have otherwise been able to have services available to them. We sought the virtual approach to reduce many barriers to attending sick kids. Our hospital is in Toronto, Canada, one of the largest cities and very busy. Lots of traffic as shown here, but also with a lot of barriers associated with in-person care, time off, costs to attend in traditional in-person services. We use the program's approach, but connect with families and ask them about their own background, their own shared experiences, identities as a parent, and experiences about their culture, race, religion, so the program can be tailored to their own family values. And as much as, important to measure the impact from a statistical point of view, I think the real life impact of programs like ours and yours is really hearing from the families themselves in terms of how it has been embedded in their program and real life day-to-day changes that they see. So the importance of families being able to have more joy, more love in their home, being able to attend school, being able to attend work itself, for families to be able to participate in day-to-day normal activities like playing with other children, attending birthday parties, and so on. So I hope that this presentation has highlighted and celebrated the Survive to Thrive program in Ghana and how programs like it can share a common mission to bridge the prenatal hospital-to-home care, to promote long-term strengthening for our caregivers and confidence in their own skills and their own mental health. These programs are rooted in evidence-based development and culturally grounded to promote developmental and mental health well-being for our children. This unified philosophy can provide a positive, powerful narrative arc, sharing across our continents how resiliency can be cultivated by these culturally grounded, developmentally early informed supports. So I want to congratulate Survive to Thrive for their initial launch and wish them continued success in many, many, many years to come, with the common goal that to truly nurture every child's potential, we need to nurture every family's potential. Thank you very much for including me in these incredible festivities and this incredible groundbreaking new direction for this program.
Thank you so much, Dr. Tricia. Please, can we show her some love? That was a very powerful message. There is a version that I liked most. She said, early identification and intervention reduces adversities and encourage stable development. That was very powerful. Thank you so much. Dr. Tricia is a neuropsychologist, division of neurology. She is also associate scientist in Canada, Toronto. Thank you so much, Dr. Tricia. We are moving on to the guest of honest remarks, and she has already been introduced. Straight away to our mama, Nanahima Awendo. Hello, Nanahima.
Hello dear, how are you? You can hear me, right?
Yes, we can.
You can. Right. Thank you so very, very much. And interesting. I'd like to first of all say a big thank you to Hope Exchange, the team, especially Dr. Adoma for including me in this amazing program. She knows that today, most especially, is not a day that I can sit down for an hour or two, but I couldn't be anywhere else but here at this time because most of you here know my passion for newborn. And of course, the fact that we are looking at going even beyond newborn and to see how our babies survive and they can thrive. I like to especially recognize Dr. Isabella Sego Moses, I like the way you explain. You recognize me and said, "I'm a good friend. I mean, I am your sister for life, whether you like it or yes." We have come this far in this journey, and I know that we have a lot more to do to save our babies and to ensure that they survive and thrive. Let me just put in a small disclaimer at this moment, because when our lady was introducing me, you mentioned 31st December Women's. I don't know where you get that information. And also, please, I'm a board member of Ghana Tourism Development Company, not the executive director, so that I am, I'm put on record as such. Thank you. I want to recognize the earlier speakers, all of them, Dr. Adoma, Mr. Dominic Osekofe, Tricia, that was a very, very good one. Very good one. Because I have learned a lot from your presentation, and I wish that probably Dr. Adoma would arrange for us to have the copy so we can take time to take it in and pick in some points on our journey to advocate on this, our journey to survive and thrive, or survive and thrive our babies. I want to specifically also recognize the work that ICPE mission is doing. I know it's a lay Catholic mission, church, or organization. But yes, you can still be a religious organization and open a medical center and just be interested in working and getting your resources, or your income might be your focus. But to pause on taking care of the poor and vulnerable, and offering services aside all the things that, people who invest in health facilities look out for. It's very commendable, and I want to congratulate you for that. Thank you so much for the work you're doing. I'd like to say thank you to Dr. Opong. PSG has been working with newborn care champions, with Ghana Health Services. In many cases, when I am on platforms talking about our babies, I meet, PSG. And we've even had opportunity of collaborating with you in Cape Coast at Women and Children's Day programs and other platforms. So I know how you're working, and I'm looking at the synergy here. I'm looking at how different organizations, especially when you ask people to give their goodwill messages, and some are coming from A and B, and how that synergy can come together to give us some kind of progress in our effort to ensure that our babies are well taken care of. So on this moment, I would like to thank the members of the hospital board, the administrator, the distinguished healthcare professionals, the community leaders, most importantly, the mothers and families that are present here today. Good afternoon, everybody. I am very, very honored to be here today. It's a profound honor, though, to be here, and we are gathered not just to launch a program, as I heard earlier that this is a movement, and we are here to witness a revolution on how we value life. For too long, in the field of maternal and child health, we have measured success by a single narrow metric, that is survival. And I remember also when we started newborn care, Dr. Sego Moses will tell you, we were looking at what is the number, 29 as death in 1,000. Those were our data. We were looking at how we are going to reduce those data. Now we are coming to 17. Then we say, oh, now we are at 15. Can we get to 12? That has been our metric. That has been our data. That has been our measurement. That's how we are looking at human beings. But who says 12 is good enough? Who says 12 deaths out of 1,000 is good enough? Who doesn't want to come home, come to our hospitals or our centers, the medical centers, and go back home with their babies intact together with a sound mother. Everybody looks forward to that. So there's no way we can even count babies as 12 deaths, out of 1,000. We don't even have the right to look at death and count them in numbers as against what is supposed to survive. So I am very excited that Hope Exchange Medical Center is not concentrating on just setting up a facility and supporting, of course, poor and vulnerable, but going beyond and seeing to it that such projects, such programs are put in place so we can ensure that going forward within the 1,000 days of a child's life, we'll be able to put structures together or structures in place. And of course, human beings who have been educated and passionate for what they stand for to be there to support our babies in their 1,000 days of life. And that's from conception to their second birthday, and it's the most critical window for brain development, physical growth, and immune health. By ensuring every child has access to continuous high quality care during these 2 years, we are building a more intelligent, a more productive, and a more resilient future workforce. And we are reducing the long-term burden on our healthcare systems and creating a foundation for economic prosperity. If the babies come out well, if we have that kind of critical support, see to it that at every step of their growth or survival or thrival, they will have somebody who is passionate about that process and will be there to support them. I remember very well when we were doing the MEPSI program, MEPSI 1, MEPSI 2, and beyond. I remember one time we went on a location. I did a documentary for the project, both 1 and 2. And one of the situations when we went to the field, one of the nurses said something that gave me chills. And up to today, anytime I refer to it, I feel the same. She says that, I don't know that we were, quote unquote, killing babies. I mean, these are very tiny things that we could have known earlier and we would have saved a lot of babies. Is it just seeing to it that you don't have infections or you don't transfer infections to babies? Or is it that you see to it that their early 3, 4, 5 days are well monitored so that they are any slight change that the baby presents can be noted by somebody who is aware, who is informed, so that the person would take note and immediately would respond to it. Even the way babies breathe, we got to know that if the baby breathes and it goes into deep in the stomach, it shows some signs. Baby signs of the eye redding or the eye bluing. I mean, the feet yellow, presenting symptoms of, jaundice, early jaundice. All these are signs that if babies present and it's noted or is captured as soon as possible, we know that our children, our babies can thrive. They can't thrive because we have put together structure and, of course, capacity for our healthcare workers so they are able to do that. So thank you, Hope Exchange. Thank you for this program. This program bridges that gap. It provides the nutrition, the monitoring, and the emotional support that turns a fragile beginning into a flourishing future. And I hope the babies will hear me. Maybe you keep this sound and play it to them later, that you are the heart of this mission. We want you to grow up with the cognitive strength to learn. Mothers who have babies on this platform, please, the physical strength to play and the health to reach every milestone with joy of our babies is our priority. We are giving you the right to a future that is not defined by limitation, by are infinite possibilities. I want to commend the administration and the visionary team behind Survive to Thrive. You are setting a benchmark that I hope every hospital in this country will eventually follow. You are moving us from culture to getting by, of getting by to a culture of excellence. This is amazing, and I will support this process through and through, anytime, anywhere. Thank you for inviting me to be here as your special guest of honor. I am honored. I don't know. I am honorably honored to be here, to be part of this mission. And thank you, Dr. Adoma. Thank you, Dr. Sego Moses, for the work you did for Ghana and the world. And our babies, we appreciate you through and through. And we will continue to tag along with you wherever you will be. And we will call you everywhere, because we cannot do this without you. Thank you, everybody. Thank you for the founders, thank you for the workers, and thank you for the partners and stakeholders. This is for us. It is not just for Hope Exchange, it is all for all of us, and we must bring our hands to the wheel. Let's all drive this agenda. May this be a start of a healthier, stronger generation. I thank you so much for having me. God bless you.
Wow. God bless you too. I could see the commitments in the speech. This is not for Hope Exchange alone. It's for us all. Thank you so much. This is powerful. Very powerful. Thank you, Nana Hima. We are so honored to have you this afternoon for such a speech. Goose pimples all over me. Goose pimples all over me. Thank you so much. We are moving on to the main projects. Without wasting much time, we'll call upon the founder, the brain behind all these things that we're talking about. And she is no other person than the well-known Dr. Adoma Odame. Hello, boss. Are you there?
Hello, Josephine. Thank you. Thank you so much. Dr. Tricia will have to be leaving us in a few minutes. So what I would like to do is to allow for any comments or questions just for her presentation, because she'll be leaving soon. You know, she is a psychologist, a developmental psychologist. She attained that at York University. She's a board-certified clinical neuropsychologist and pediatric subspecialist through the American Board of Professional Psychology. And she currently is the clinical neuropsychologist in the Division of Neurology and associate scientist in neurosciences and mental health. And she leads the neonatal neuropsychological services for assessment and consultation for children following neonatal brain injury and associated medical conditions. I just wanted to put this out there because I know that some of us may have a few questions regarding newborn health and the psychosocial, psychological issues, newborn health and mental health issues of the newborn. So I just wanted to put this out there. If you have any comments for her, any question for her, we'll just give you some 5 minutes to ask so that when it's her time to leave, she's able to do so. Josephine, I crave your indulgence, Madam MC.
All right. Please, if you have any question, like my boss said, kindly let us know. Mr. Fred Ayensu and Ms. Eugenia, kindly moderate the questions for us. Please, do we have some questions, Mr. Ayensu? Is Mr. Ayensu here with us? Miss Eugenia, kindly check through the chat if we have some questions.
Okay, I guess there are no questions
Hello,
for.
Joe. There are no questions. Yes, there are no questions at the moment.
Okay, that's fine. Then I will go ahead with my presentation, after which Priscilla will follow, and then Dr. Sheila will also follow. So, Survive to Thrive, the Hope Exchange model. We'll just take a brief intro, look at the problem, and then why we came up with the Survive to Thrive concept. I hope my screen is seen and is well seen.
Yes.
Yes, so
please.
Trisha, contrary to your snow, I have a lot of bright sunshine here. So you can come for some at any time. So this is the frontage of Hope Exchange Medical Center. Good. So now let's start. Are health challenges in our children always easy to identify? On the top left, you can see a child obviously has vitamin A eye signs, easy to pick up. The father carrying the preterm baby may have developmental challenges. We may pick up CP. We may pick up challenges later on in life. The children at the bottom, obviously you can see that there's childhood obesity. They are having health challenges. But the one in the middle, are we able to pick up any health challenge? Maybe not easily by just looking at the child. We may need to do a lab to find out that there is iron deficiency anemia. Let's come to another health challenge that many times you overlook, the mental health component. I sent a young man some years back, to go and buy me Hausa cocoa for myself and then another lady. And this young man, so I wrote it out for him. So Barbara wants Hausa cocoa 1 cedi. Ya also wants 1 cedi. I am the ya. And then I wanted peanuts 50 pesos. Barbara also wanted the same 50 pesos. And then I wanted Kose 50 pesos. Sorry, Kose 50 pesos. Same for Barbara. And the total I wanted would be 2 cedis. Total for Barbara will also be 2 cedis. After an hour, this boy still hadn't come back. So I was wondering, has he run away with our money? What has happened? Only to find him coming back slowly, head and shoulders all drooping downwards, to tell me that he got the Hausa cocoa, he got the peanuts, he got the Kosi, but he couldn't get the total to buy. He had gone to the total filling station, as some people had directed him, but they said 2 cedis total there. They don't know what it is. Sometimes the cognitive abilities, how intelligent a child should become, is dependent on what happens within the first 1,000 days of life. We set the child on the trajectory to excel, to do well in school, or on a trajectory not to do well, to drop out of school and earn even 10% less than a child who is well fed. These are some of the challenges we have within our health system. These are some of the challenges that we have in the lives of our young children. These are not things that are killing the children. So it's not helping them. It's not an issue of survival, but these are things that are related to thriving. Let's look at the developmental window. I know I'm going to be preaching to the choir here, but we know that the brain of the child develops through complex dynamic interactions between what happens biologically and experiences in the environment, the nurture and nature balance. It begins at conception and it continues all the way throughout life. And during the early years, from conception to about 2 years, rapid things are happening in the brain of the child. A lot of things are taking place. Synapses between the neurons are forming and are being reinforced. So early childhood is a window of great vulnerability and also a window of great potential. That's why early childhood is a place where we need to focus on. Policymakers, leaders in our hospitals, and in and without the health system, we need to focus a lot on the period of early childhood. Still on the brain of the child, we know that every child has the right to optimal cognitive, social, emotional, and behavioral development. And if we don't optimize brain development, what happens? Consequences to job potential, to education, and even adult mental health, from the mental health of a child to the mental health of an adult. Three factors have a profound effect. One is toxic stress and inflammation. Another is social support and a secure attachment to the mother, to the primary caregiver. And optimal nutrition is also very important. Periods of critical brain growth in terms of volume, in terms of size. By the time the child is 2 years of age, the brain is 75% of the adult size. This shows you how much is really going on within that critical period. So it is not enough, and let me say it here, it is not enough for us to put our least trained, our least creative in touch or taking care of these children. And I'm not talking about the hospital environment alone. I'm talking about from the home environment all the way through to school, to hospital, wherever. You know, we like to put the most highly trained in the universities, teaching the PhD students, reasoning at higher levels. But the children, the little children, need people who are adequately trained to be able to get them to expand their mental capabilities, to get them to be invested correctly within that period. It's very important. This is just a picture showing us the neurons and showing us that the newborn to the 2 years of age, realize that there are so many synapses occurring between the newborns and the 2 years of age. And then it becomes pruned to the adult phase. So realize that if you look at the neuronal connections in the 2-year-old, it's haphazard. It's like a crazy artist, but it becomes pruned based on the experiences that this child goes through. So we have a role to play as healthcare workers, as parents. Let's move on. So this picture just shows us that a lot of things begin happening even before birth. Look, -1. Even before birth, seeing, receptive language, the child can hear in the womb, the child can see in the womb, the child can feel in the womb. So my ONG team, my midwives, it's important for us to teach the mothers, talk to your child, sing to your child as your child is in the womb, because the child is hearing you. And remember that the foods that you eat when you are pregnant, some of them actually are tasted by the child through the amniotic fluid, and the child has a better acceptability of those foods when he starts eating and is being weaned. A lot happens preconceptually and before birth that we are not really looking at. We are just looking at, the child has come, life starts from there. But life doesn't start from there. It starts way before. Stunting syndrome, we also know that it occurs early on, right from conception throughout to 2 years of age. Stunting syndrome begins to happen. And if you're not careful, we may not be able to put in place interventions to be able to, for want of a better word, save this child. So what really are these first 1,000 days of life, the term that we've been using a lot? We talk about from conception through to the second birthday. It's a very important determinant of fetal growth, cognition, obesity, and even non-communicable diseases later on in life. If you get metabolic syndrome as an adult, it can be traced down to things that happen during the first 1,000 days of life. If you're having mental health challenges, as was shown during the Dutch hunger winter, it can be traced down to what happened within the first 1,000 days of life. Now the movement is even going beyond the first 1,000 days of life to the next 1,000 days of life, because we're realizing that that whole period is still very critical. But this is the period that we are talking about now, and what we are doing Survive to Thrive about. It's difficult to reverse stunting after 2 years of age, and that is tragic, isn't it? And stunted children lose about 3.2 centimeters in their adult stature for every decrement in the HAZ at height for age Z score, at 2 years of age. So this picture just shows you something, and I just want to look at the bottom part. If a child gets good nutrition during the first 1,000 days, he's 10 times more likely to overcome life-threatening childhood diseases. He's able to complete 4.6 more grades of school. He's unlikely to drop out of school. He's unlikely to be failing his exams, all because of good nutrition within the first 1,000 days of life. Now, this is the beautiful part. He's likely to earn 21% more money, cedis, dollars, yen, pounds, as an adult, as compared to somebody who was deprived or malnourished within the first 1,000 days of life. And this is where it goes beyond one generation to another generation. He's likely to have a healthier family. He's likely to be able to take better care of his children, her children, and they are likely to be more healthy. And it just goes on from generation to generation. So if we invest within the first 1,000 days of life, what are we doing? We are breaking transgenerational poverty, transgenerational failure, transgenerational health issues. We all know about the economic burden when it comes to malnutrition, how it impacts non-communicable diseases, obesity, etc. And we also know that school performance, like I already said, is affected, by stunting, by malnutrition, by what goes on within the first 1,000 days of life. And it's important for us to know this, that many newborns are unable to reach their 5th birthday, all because of correctable nutritional deficiencies. I'm talking a lot about nutrition because breastfeeding is so important, and we'll talk about it during Priscilla's slides. Nutritional assessment, nutritional counseling is so important. One of our strong points in the Survive to Thrive program is this. And it's funny, Priscilla, who's the head of the program, often gets called into discussions in people's houses. They'll call her on the phone and say that, oh, my mother-in-law says that I should stop the exclusive breastfeeding. Otherwise, baby will not gain weight, or otherwise, baby will not do this or do that. And Priscilla has to come in and say, no, exclusive breastfeeding is life-changing. It sets your child on a trajectory for success in health, in all other areas. And so you realize that help that is given, that extra voice that comes in, that healthcare worker support that comes in, even to the home environment, even to the mother, you realize that it is so important for these parents. So for those of us who will be going forward to start our own projects, you may call it whatever you want to, let's really incorporate that aspect that focuses on breastfeeding and nutrition. Now let's come to Ghana. Let's have a picture. Let's take a look at the picture of Ghana. What is happening in Ghana? Under 5 stunting is still taking place in Ghana. Adolescent births, preterm births are all still taking place in Ghana. And you know that once you have adolescent births, these teenagers are not able to fully engage their young children, stimulate them mentally, provide responsive caregiving. So these children normally will end up with some challenge or the other. They may have challenges with executive function, etc. Childhood poverty still exists in Ghana. We're looking at 6%. This was for 2025. And you can see mortality to your extreme left. And then you can see the various components of the nurturing care program: nutrition, responsive caregiving, safety and security, early learning, and then health. And the breakdown shows you what is going on within our homes. 34% of our mothers are stimulating our children at home. And this is the most painful part. And I know some of us here will be guilty. 7% of our children have books in the home. And this is not their school books that they were given by force. Every day is packed into their bag. No, their own storybooks that they play with, that they read. Only 7% of our children are having them. So 50% of our children are having playthings at home. And playthings at home, we are not talking about tablets. We are not talking about television. We are not talking about screens. Because you know that the science is clear that screens before the age of 2 is not helpful for our children. It's related to ADHD. It's related to delay in speech, delayed developmental milestones, anxiety. And even now, some developed countries, I think Australia and some other countries, are trying to ban social media even up to the age of 16 years because they are realizing the adverse effects that it is having on these children. So when we are talking about playthings at home, please, you're not talking about tablets, you're not talking about screens. We're talking about toys that will help these children build their motor skills, build skills of negotiation, etc. So why did we start Survive to Thrive? Now, this is the reason. So this is data from our hospital, Hope Exchange, 2024 data. We had 27 cases of children with undescended testes. And the age range was 5 months to 12 years. So we're having 12-year-olds coming in with undescended testes. Now, this is what is worrying, what is in red. The median age at which they were coming to do their surgery was what? 5.3. That was 2024. The median age in 2025 is what? 5.2. What does this mean? These kids are having their testes within their abdomen up to the age of 5.3, 5.2 years. And you and I know that the children are supposed to have these testes brought out way before that. Otherwise, there's a risk of malignancy and there's the risk of infertility. But we have children as old as 13 years old. Look at those who are above 10 years old. 13% of the children were more than 10 when they came in for their surgery. What does this mean? They are at high risk of having male infertility. Male infertility, think about all the psychological stress it is going to bring into their families. Think about the psychological stress it will bring for the wife who will marry this gentleman. What it will bring for the family of this gentleman, and how much assisted reproductive technology costs, ART, for them to now be able to have a child. And balance all this as against you and I doing an examination on the baby, seeing that testis hasn't descended, referring to see the pediatric surgeon who will bring these testes down for us and will take this child off that whole trajectory of infertility, ART, and all the psychological trauma and stress. This is why we need to have programs like Survive to Thrive, to be able to follow the children up, to be able to track the children. Cities and the quality of life. You have mothers who come in who are having problems with breastfeeding, like I mentioned Priscilla's scenario before. And because there's nobody to hold their hand, to tell them that you can make it, you can do it, don't be worried, I'm with you, the breast milk will come, the child will gain weight, his stools will normalize. What your mother-in-law is saying, well, that is what she did, but that is not what is in the best interest of your child. Let me talk to your mother-in-law. When you have somebody who's able to hold the mother's hand, the new mother's hand, through that critical period, first month of life, second month of life, take it one day at a time, we will end up with better rates of breastfeeding. And you know that in Ghana now, our breastfeeding rates are falling, partly because of what is happening on social media, breast milk substitutes, marketing, etc. But one thing that I have realized is really important is the mothers having somebody to hold their hand, telling them, let's take it one day at a time. On one of our chat groups in the Survive to Thrive program, one mother you could see from the way that she was talking that she wanted to start formula. The baby is not crying, the baby is not getting enough milk, the baby is not full. So you could see that this one wants to start formula. So Priscilla reached out to her one-on-one, talked with her, let her know that, come in, let's have a look. It was a problem with attachment. So once baby was now able to attach well, he feeds well, come and see baby. He sleeps. He does his 3 hours for mother to also get her rest in between the feeds. So if we are not able to help these mothers do this, then the children are put on formula. They end up having recurrent respiratory tract infections, diarrheal diseases, and all the problems that we know are associated with formula feeding. All this can be prevented when somebody helps the mother. And think about how much the mother will lose in terms of how much she has to spend buying medicines, spending time in the hospital, staying in the hospital because the kid has gotten a severe respiratory tract infection and has been admitted. As opposed to us just talking to the mother, holding her hand, walking her through, and then protecting this baby. Let me talk about Kofi, a 7-year-old who I saw. Clearly, this boy had a congenital heart disease. He was clubbed, he was blue, he was plethoric. And the mother, so when I did all the labs and the x-rays and everything, the echo and everything, it confirmed what I had thought already. So I was amazed. He's coming in at 7 years. And I said, so have you not ever realized something unusual about your child who has a tetralogy of Fallot, congenital heart disease? And she said, he easily gets tired. He's always squatting every now and then. He easily gets tired. He's always squatting every now and then. But I thought that he was just a lazy child. Can you imagine? This child would have wanted to play football. He watches his friends playing football. He's always suffering ill health. And it hadn't been picked up throughout infancy. It hadn't been picked up that this child has a congenital heart disease. Consider how much this child has lost, how much he could have done that he hasn't been able to do. He has lost, all because we didn't listen and we didn't pick it up. It's so important that we have in place programs such as Survive to Thrive. It's based on the WHO UNICEF model of adequate nutrition, good health, or early opportunities for learning, safety and security, and then responsive caregiving. So what did we do? We reviewed the existing programs, and then we also reviewed protocols and policies like the WHO Well Child Visits, American Academy of Pediatrics, their Healthy Stats, USAID programs, UNICEF programs, and then Ghana Health Service. And then we tweaked the programs to be able to see what would fit within our terrain, what would fit within our jurisdiction, because realize that things culturally, our context is a bit different. For instance, after 2 years of age, many of our mothers will not be coming back for their child welfare clinic visits. They may not come. So there are certain investigations that may needed to have been done at a later age. That's in our program. We are doing them earlier. What are our program objectives? Improve newborn and child survival, early identification of developmental problems, and educate and empower the caregivers. And as Dr. Tricia said, build resilience into the children by empowering the parents, by helping the parents to be able to take good care of the children and to be able to raise resilient children. So what did we do? We designed the program. We had some nurses trained in developmental assessments by Dr. Brew. Dr. Brew is on the call with us. Thank you so much, Dr. Brew, for training our staff. And then we appointed the program coordinator, that is Priscilla. So it has two main components. One is the in-person visits, in which there's immunization, nutritional counseling, physical examinations, physiotherapy. We love massaging. You know, we by culture, we like to massage. So we've just medicalized the massage. We get the massages done for the kids. There's anticipatory guidance, safety and security education, neurodevelopmental assessments, the lab test, maternal depression screening. And we have picked up 1 or 2 mothers who are depressed, and we needed to refer them to the psychologist. And then we also have cooking demonstrations and then toy making. Priscilla will tell you about these ones. Normally, the cooking demonstrations, I like to sit and collect some of the soup because the kids' soup is just amazing. You just need to add fufu to it and your day is made. And we also teach them how to make local toys. Then we have the social media engagements, the WhatsApp group, YouTube page, and then the phone calls. Benefits to the facility: improve patient outcome, enhance quality of life, increase patient satisfaction and trust, stronger community reputations, and even staff satisfaction. Some of the challenges that you may face and that we may also face include funding. You know, when it comes to the lab test, they need to have G6PD, HV electrophoresis, they have to have ENT assessments, vision testing done. These cost money. If you put it all together, it costs around 500 to maybe about 800 Ghana cedis per child. And because it is preventive and it's not curative, health insurance does not cater for it. So that is what may be a bit of a challenge. So what we are doing now is that right from the time we're enrolling them in infancy, we are letting them know that they will need to pay this amount later on in the future at 1 year or 1.5, so they can save towards it, or they can even come and start paying towards it every time they come for the clinic. It would be great for us to be able to get it on health insurance because preventive care saves us a lot. It saves us a lot. As the saying goes, a stitch in time saves 9. So preventive care really saves us a lot. And children, the dividends are huge. So we're really good to get us to be able to get it on health insurance. Another challenge may be the continuity after 2 years of age, because remember, our mothers don't often come after 2 years, but we are working with our first cohort. We'll see what happens at 2 years of age. And then the third issue has to do with staffing. Sometimes it's not so easy to get staff released just to be able to run this clinic. And these may be some of the challenges that some of you may face as well. I'm ending and then going to hand over to Priscilla. We'll be having a neurodevelopmental workshop organized in collaboration with Dr. Brew of Greater Accra Regional Hospital. And they are going to teach us how to do the developmental assessments for the children. And this is so important. So you can know which child is not gaining his milestones, who needs to see physio early, who needs to see eye early, who needs to have some other intervention done early, picking up autism early. So any of you who want, you can just take a snapshot of this. We'll be having this program on the 26th and 27th of February. and you can just call Priscilla or message them and then register your staff. Even though early bird is over, we'll still give you early bird for the sake of those of you listening in today. We'll allow you to do early bird at 500 cedis for the 2 days. Okay, so I'm concluding by quoting Gabriela Mistral. She said, "Many things we need can wait, but the child cannot wait. Now is the time that his bones are formed, his mind is developed. To him, we cannot say tomorrow because his name is today." Let us put in place whatever clinic it takes to be able to make sure that each child survives and thrives. The child doesn't just survive, but the child thrives and able to achieve his potential. Thank you very much. I'll hand over to Priscilla to now continue with what goes on in the clinic, how to set up your own clinic. Priscilla, over to you. Priscilla is our Survive to Thrive program head. She's a community health nurse by profession and by training. Priscilla, over to you.
Okay, thank you very much, Dr. Adama. I'm Priscilla. Dr. Adama, I'm a public health nurse.
Forgive. I'll buy you a good. Forgive.
Okay, so now we have a concept about Survive to Thrive. And Dr. Adama, can you please share my slides?
Okay, let me is this slide okay for you?
Yes, please. Okay, thank you very much, Dr. Adama, for such a program. You are the brain behind this massive program. And now we have a fair view of what Survive to Thrive is. And I'm going to take you through how you can set it up in your own facility. So the preparation phase, you need to set up a Survive to Thrive clinic. Staffs who are willing to do this. It shouldn't be I'm quoting by forcing it on people, because you need to get the passion to be able to set up this clinic, because the mothers will be calling you at dawn and at odd times that you may not be in the mood to respond, but because of the passion, it will push you to help the babies thrive. So you create awareness of this program at the various OPD in your facilities. So you go to the various OPDs, the main OPD, the ANCs, anywhere you see people gathering in the facility, you talk to them about Survive to Thrive. Let them know the reason why they have to be part of this program. And you inform the ANC and the CWC staffs about the clinic. You place a book at the maternity and the labor ward for new babies. Then you tell the ANC and the CWC staff to refer every baby less than 3 years to join the Survive to Thrive clinic. So you refer them to the team. Dr. Adama, please. Okay, so once the baby is out, you take the data of the babies from the maternity ward, the child welfare, because that is where majority of people do come with babies, and that is where we do get babies. And the babies will be coming there right after delivery until their second birthday. So this is the very good place for you to take your data. So the maternity, you already have a book there, so you go for the book, but you still have to go there to see the CWC, the BCG. I didn't add NICU because Survive to Thrive is mainly for well babies. And you know, the NICU, they also have their own way of doing their assessments for the babies. But they do join us when the babies are okay, there is nothing wrong with the babies, then they join the Survive to Thrive team. So you take data from the CWC and the BCG immunization. During BCG immunizations, you do get mothers who deliver at facilities that don't give BCG immunization. So they do come to our facility to take it. So you take data from them too. The data we are talking about is the date of birth of the baby and the mother's contact, only if it's on WhatsApp, sorry. So during the BCG immunization, you take that opportunity, not just going there to take data, you take the opportunity to educate the mothers on exclusive breastfeeding and the care of the baby, the newborn especially. Then you take the contact, as I've already said, educate mothers on the Survive to Thrive during BCG immunization. Let the mothers know you are going to add them to a particular page, and that page you are going to learn about how to help the babies thrive, not just giving birth, not just looking at your child saying, I've gotten a boy, I've gotten a girl, the weight is this, the weight is that. To help the babies thrive is our main goal. You seek consent from the mothers before adding them to the page, and it's an oral consent, not necessarily printing anything out to show to the mothers. Then you create a WhatsApp page. Once the WhatsApp page is ready, you introduce yourself to the mothers, let them know who you are. You put your personal telephone number on the page for the mothers to know so that they can call you. Sometimes we have numbers for WhatsApp and numbers for calling, so you should let them have both of them if you have different contacts, please. Okay, in the phase 3, once we've created the WhatsApp page, we educate mothers on health promotion topics like exclusive breastfeeding, care of the newborn, how to bath them, any topic that comes in mind. You have to talk to the mother, and it should be periodical. It shouldn't be just once and the following time you are not doing it, or 3 months later before. The page must be active. You send an audio education with pictures on the page always. Allow mothers to give feedback and ask questions using audio. Because if you are strictly going by typing or writing, some of the mothers are not able to type or write, and they would be having a problem, but they can't tell you. So you tell them that we should all send our questions or feedback through audios, and with the audio, it's very simple. Everybody can do it. Dr. Adoma, please. Okay, so this is a chart of the for the main clinic of Survive to Thrive, how we go about it. So immediately the baby is out, we do newborn assessment, immunization, breastfeeding counseling, anticipatory guidance for the baby, and it can be done by the NICU. The newborn assessment is normally done by the NICU or the midwives, and the immunization, child welfare clinic, the breastfeeding counseling, Hope Exchange Medical Center. We have a lactation department where mothers go for counseling on exclusive breastfeeding. Then anticipatory guidance, what the mother should expect as the baby is growing. That is done by the Survive to Thrive staff. Then we do baby assessments when the baby is 2 to 3 days. We do repeat the assessments, and it's also done by the NICU or the Child Health OPD at Hope Exchange, so you can find a way of doing your own. And when the baby is 1 month, the baby comes for a physical assessment, vaccinations at the CWC, hearing assessment, and maternal depression screening. That is done by the Survive to Thrive team. And when the baby is 2 months, to anticipatory guidance, you go assessment, vaccinations, as we always do. Dr. Adoma, please, can we go? So this is a table of what we do in Hope Exchange. This is how we've scheduled our visits for the mothers. So each visit has a particular assessment or what we have to do for the baby. So when the baby is 4 months, the baby also comes for assessment, and 5 months, the baby also comes. But we do have mega clinics that we do for the babies. The mega clinics, we group the mothers. Sorry for not telling you this. When the mothers deliver, we group the mothers according to their birth of month, the babies, according to their birth of month. So we are in the month of February. So if you are going to set up Survive to Thrive, starting from, let's say, February, which is not late, you can group the mothers. All babies born in February will be at a particular WhatsApp page. Then you name the page, let's say February 1 or February 26, so that you know, because it's a continuity of thing, and we are not going to stop it. So you have to give a unique ID that anytime you go there, you see that, okay, these babies were born in February 2026, or anyhow you want to name it. It depends on you. So every 3 months, we do a mega clinic for the babies. So let's say baby is born in February 2026, March, April, May, we have a mega clinic for them. 3 months after that, we have another clinic. Babies born in March, April, May, they will have their clinic. Babies born in April, May, June, they have a mega clinic. And then in the mega clinic, Dr. Adoma, please, let's show the mega clinic. In the mega clinic, okay, so this is a mega clinic for babies who were 2 to 3 months, who are 3 to 3 months. So when the babies are within 2 to 3 months, you group them, you put it on the page a week before the date that this particular day, mothers, we are coming to meet, we are coming to discuss how to help our babies thrive. We are coming to give, we are going to have an assessment done. Mothers really love this assessment. If you tell them you're going to have an assessment done for the babies and it's free of charge, everybody would love to bring their babies. So let them know why they have to meet, even though they've come for the child welfare clinic. Let them know why they have to still come and meet at the hospital for the mega clinic, because the mega clinic do help the mothers too. Sometimes they come and they build this mutual relationship among themselves, because they'll realize that they all gave birth in February, and someone may think my baby is too small and will come and will say, oh, okay, February babies, oh, we are all like this. It's the same month and we are all thriving together. And some mothers who have 4 to 5, more than 3 or 4 or 5 children, I call them the experienced ones. You see them around and they'll be helping you answer questions that newborn mothers will be bringing out, and they'll before you know, they've already formed their own page or their own group that they are discussing, and anything that they think is about them, they will call you and you clarify it. So when babies are 2 to 3 months, during the mega clinic, we give health education on nurturing care. Dr. Adama already said it. It's about good health, adequate nutrition, responsive caregiving, safety and security, opportunities for early learning. Dr. Adama, please, the next. Okay, so when they are 2 to 3 months, we do assessments. We take the baby's weight, hair circumference, length, and temperature of the baby. Then, after doing these assessments, we refer the baby to the physiotherapist. So if you don't have a physiotherapy, you can teach the mothers on how to massage the babies, educate them on tummy time. You also teach them how to massage the babies when they complain of, let's say, colic or gas or bloat. The babies are bloating. If you don't have a physiotherapist, but if you have a physiotherapist, the physiotherapist should inform the physiotherapist about the clinic, and they set up at where you are with the mothers, and they do these teachings for the mothers. So at Hope Exchange, we have a physiotherapist, so you could see there's physiotherapist around. That is the mat where there's physiotherapist, the guy there and the lady with a red shirt. They are the physiotherapists in Hope Exchange Medical Center. And you can see the babies, one baby is on the floor teaching them the tummy time, educating mothers on why they should have these times for the babies. But I'm not, please, the next slide. So after referring them to the physiotherapy, you let them meet the neurodevelopmental screening team. So as Dr. Adama said, we'll be doing a neurodevelopmental workshop at Hope Exchange Medical Center. And I think if you want to set up a Survive to Thrive clinic, you would need a neurodevelopmental team. They are doing the chunk, the majority of the work is done by them. So you could see them, they used this assessment sheet. Dr. Adama, please, can we see the assessment sheet? So this is what they use in education. So when you come to the clinic, the workshop, you have a fair knowledge about everything that we are talking about, and you appreciate it. So this is a summary sheet for 8 months baby, and anything that an 8 months baby is supposed to do is on this sheet. So the team, they do assess the babies using these marks on it, and they have a score. If the baby scores below the average score, that is when it's alarm, and you have to refer the baby to the specialist that the baby needs. So you screen baby using this summary sheets based on on the baby's age. So unfortunately, when I was looking for this, I just got the 8 months old. That was why I stayed. But we have it from 2 months to 5 years. Dr. Adama, please. So after all this, you refer the baby to the nutritionist for nutritional counseling. Remember, it's a clinic for babies who are 2 to 3 months. So the nutritional counseling is solely on exclusive breastfeeding, and the nutritionist counsels the mothers on how to improve breast milk production, not just how to position the babies, but how to improve breast milk productions. Because as Dr. Adama said the last time, we had a mother who was complaining bitterly, my child is not gaining weight and my child is always crying, she doesn't sleep. We told her to bring the baby for us to see, and when it came, we realized it was attachment, and the baby was attached very well, but the mother wasn't feeding very well soon. So the mother was referred to see the nutritionist, and he gave her counseling on what to eat to promote breast milk production. And now the mother is really happy, and she even sent us an audio that we play for everyone to hear. Dr. Adama, please, the next one. So every baby sees a pediatric nurse or specialist or pediatrician or a medical officer. So after doing this, after doing all the talking, all the education, all the assessment and screening, then we refer the babies to see a a pediatrician, a nurse specialist, or a medical officer. Anyone. Even the Survive to Thrive team, if in facilities that you don't have, I know people at the CHIPS compound would love to also do. And in the CHIPS compound, we know we don't have a medical officer there. So one person, part of the team, can be because in the CHIPS compound is the nurse who does everything. So one nurse can also do this. You can assign one person as as a medical officer or something that the mother needs to see. So this person will do a thorough physical examination on the baby, so that in case the physiotherapist, the neurodevelopmental team, or any other person who took care of the baby missed something, the medical officers will know and will query. Please, Dr. My next slide. Okay, so mega clinics for babies 5 to 6 months. So when the babies are 5 to 6 months, they also come to the clinic, and they also come to meet. And there we do assessment as we did when they were 2 to 3 months. So you could see it's 3 months after the first clinic. Now they are 5 to 6 months. So when you start Survive to Thrive, let's say Hope Patient Survive to Thrive is a year older. So every month we have babies coming. Every week we have babies coming, because babies born in last year, January, are 1 year, and they came for their 1 year clinic in January. Babies born in February, they are now 11 months. And so the last week of February, we'll be doing their clinic for them. Babies born in March, you have babies born in November who are coming in next week for their 2 to 3 months assessment. So every day, every week, you have something to do for the babies. So this is the mega clinic for babies who were then 5 to 6 months. So when they are 5 to 6 months, we did 5 to 6 months because some mothers, they will tell you, I'm going to work, I need to start complementary feeding. Some will tell you once the baby is left with just 2 weeks for the babies to be 6 months and we are starting complementary feeding, and they wouldn't do it well. So we use babies 5 to 6 months. When the baby is 5 months going to 6 months, we meet together. We do this assessments we did when the babies were 2 to 3 months, and we do a cooking demonstration too for the mothers. And the cooking demonstration, I always urge us to use our own locally available products. We shouldn't tell the mothers to go out and get these formulas that some cannot afford, and it won't encourage them to even be part of the program. So with the program, please, when we are giving education, we should always limit it to the traditional way of taking care of the children, the ways that is not harmful to the children, but the ways that will help the babies. So you shouldn't tell the mothers that you should put the baby in a cot. Don't put the baby by you, and some mother cannot even afford a cot. So you need to let her know where to place the baby if she's sleeping with the baby on the bed. How? Because in our certain African setting, 60% of us, we don't put our babies in a baby's cot. So, and if you are doing, because you are doing Survive to Thrive and you think it's a WHO and UNICEF initiative, and they say we should always put the babies in the cot, so you'll be forcing the mothers. Some mothers cannot afford the cot, and the babies may also be suffering or having a problem, but they can't tell you because they think when they call you are going to ask of the cot or something. So I always tell my team, the nurses, to always talk to the mothers using our traditional way of taking care of the babies, which isn't harmful. So you teach mothers how to prepare homemade toys for the babies. And I once made a homemade toy, for the babies, and it was really fun and very nice. Subsequent ones is made by one of my team, Rita. And I used the socks, normal socks, and I packed in cotton wool. It would be cotton wool or any used rag or something that the mothers doesn't want to use again. It can even be sachet of water. You packed it inside the socks. Then you use a tie or a rope, a band to tie it, let's say into 5 sections. After that, you just use a button. You just use a button with a needle and a thread. Then you put it at the edge of where you tie at the end. Then it's if you are going by me, you see you get a fair view of what I'm talking about, and it will look like a snake. And when you shake it, the baby will like it. And use the socks that is colorful. It's unfortunate that I misplaced the phone and I didn't get a picture to show you. Dr. Adama, please, let's go. So we use this teaching. You educate mothers on oral health too, since the children are now going to eat. So with this, before you start all this education, I've already told them we are going to do a food demonstration or cooking demonstration. This is what we are going to cook. We are going to cook porridge, and I'll show them this is my corn dough. This is the butter or the margarine I'm going to use, and this is the fire, this is the water. I'm setting it up in front of them so that they wouldn't think you went to do it somewhere. It's not, the children are going to eat what you didn't say, or what the children are eating is different from. So whilst the porridge is on fire, we are cooking my team, some people are cooking the porridge. I'll be there giving education so that we don't waste time. If you say you are going to cook everything before you come back to give education, to do certain things, the mothers will end up staying too long at the facility, and the next time when you call them, they wouldn't come. So we don't waste time during our cooking demonstration. We start the cooking. That's the first thing that we do. We tell them we are going to cook porridge, and this is the corn dough we are going to use. This is the butter, everything. So when we are ready to add anything up, I pause with the education, or the one giving education pauses. Then the one doing the cooking will come and tell them, it's time to add this. So I'm going to add. So let us all see. And the utensils or the things that we are using to cook is right before us or at the back of us. So when she says that, we all go to see. After we come to sit, then we continue with education. So by the time we are done with education, the food will be ready. We serve ourselves, then we eat. Dr. Adama, please, the next one. So this is a picture of my team preparing. This soup was a Ghana soup that we prepared, and the babies loved it. And we had visitors from Malta, and they came to see what we were doing at Survive to Thrive Clinic. And this baby was crying that she wanted to be with the white lady, so we gave her. She was feeding her with the fruit juice that we made. It was a watermelon fruit juice. Dr. Adama, please, can we go? Okay, so we do maternal depression screening using the PHQ-9 chart. If you go online, it's a very simple chart that we use for the mothers to assess them if they have maternal depression. And this screening is done when the baby immediately when the mother comes for the first clinic, first month. You do this screening for the mothers. When the mothers come 3 months, you do, and 6 months we do. We do this until the baby is 1 year. So this is how it looks, and it's very simple. And that is the score that you see. When the mother scores 0 to 4, you know the mother has no problem. If the mother scores 5 to 9, mild, 10 to 14, moderate, 15 to 19, then you refer to the psychiatric department. 20 to 27, I think the mother needs to be seen by a psychiatrist. The mother needs to be counseled very well. Dr. Adama, please, the next one. And please, with this screening for depression, it should be done separately. We don't do it together, and we don't even tell the mothers. During the anticipatory guidance that we give to the mother, that is where you put the sheet in front of you, then you be asking the mothers. You don't let the mothers know you are screening them for depression, but as you are talking, as you are having this counseling with the mothers, you'll be asking them the questions in between, then you'll be marking, you'll be taking. So based on the score that the mother gets, you know this mother needs to see a psychiatrist, or this mother needs this particular education, because anticipatory guidance is not on just one particular topic or education. Anticipatory guidance is broad. It's any education that helps the babies, to thrive. So anything that the mother goes through goes away to affect the baby. So during the counseling, you'll be asking the mothers, asking the mothers, and you'll be marking them in your mind, and you know at the end, oh, this mother scored 0 to 5 and she's fine. Oh, this mother had 90. No, I need to change the topic. So immediately, quickly, you change the topic to where you think the depression is coming from. Then you start with the counseling for the mother, and you will know if the mother is picking up, and if you think the mother is not getting what you are saying, that even if you start with this depression counseling, the mothers will even come out telling you wholeheartedly what is happening to them and everything. But if you tell them you are screening them for depression and what they are going through, they think it's personal, they will not tell you, they will not even give you the right answers. But so whilst you are giving anticipatory guidance, counseling, then you'll be using these tools to assess if the mothers are depressed. Dr. Adman, please, the next one. So this is a mega clinic for the mothers, for the babies when they are 9 months. There we do the assessment to physiotherapy. The neuro assessment is also done. Oral health, we continue oral health until our expiring days. We don't end. So once oral health starts, it should always be there. So mega clinic at 10 months, assessment anticipatory, we do 11 months, we do. So as I showed you the clinic, the schedule for our clinic, this is how we do it. Every 3 months we do. So mega clinic when the baby is 12 months. So when the baby is 12 months, the baby does the assessment, physiotherapy, the anticipatory guidance. That is where we need it mostly, because at 12 months, 2 years, some mothers will be preparing to get another baby and they will start neglecting this baby. So when the baby is 12 months, they need the anticipatory guidance very well, the counseling. Vision test, we do vision test when the baby is 12 months old, and ENT assessment, that is the ear, nose, and throat assessment when the baby is 12 months. Sadma, please, let's go. So when the baby is 12 months, we also do some labs for the baby. We do HP electrophoresis, then we do sickling for the babies, and we've added blood grouping for the babies too. So Hope Exchange are babies the babies we started with, those born in January, between January and February, they'll be 1 year. Let's say the last week of this month, we expect all of them to be 1 year. They will be meeting on the last Wednesday of this month to do this screening for them. So 18 months too, we do assessment, then we do full blood count and urine. Then we do autism screening, because that is the main time. By this time, babies will be walking. By this time, we expect babies to be able to say 1 or 2 sentences, and that is when you can rule out autism in the babies, because at early stage it's very difficult, if you are not a specialist, to know this baby has autism or something. So when the baby is 8 months and on, you can really tell if the baby has autism. So we do autism screening, vaccination, but our babies are not yet 18. Our first babies are just 13 months and 12 months. So when the baby is 24 months, we do assessment, we do HP, we do repeat the HP electrophoresis, and neuro assessment is also done. Oral health anticipatory guidance is also done. We do this anticipatory guidance. We plan on giving it out, telling the mothers how to prepare the babies for school, what the babies needs, how to take care of the babies when they start school, so that all this that we've done, the babies will not go to school and we will end up losing so many things, because we all know that when the baby starts school, they come in with these viral infections, and so we need to psych the mothers to be prepared for this, so that any viral infection will not affect, because it can go a long way to affect the babies, and we may even lose them because of the temperature that the babies will have. So thank you very much. Dr. Adama, please, the next slide. So thank you very much for your time, and I hope everyone will go and set up a Survive to Thrive team. And you have my contacts on the flyer. So in case you want me to help you set it up or anything, you can call me. We can have a video call, a WhatsApp call, or a normal call. You can visit me, then we go by that. Thank you very much. God bless you. All right, we continue with another presentation. Yeah, Dr. Sheila will do that for us. Hello, doctor.
Hello, good afternoon. Please, can I be heard, and then can my screen be seen?
Yes, please.
Okay. So, good afternoon, everyone. Briefly, I am supposed to talk about considerations for research when you are setting up a project like the Survive to Thrive. From Dr. Aduma and then our last speaker, we all know that the main aim of this project, or one of the aims, is to scale up across the country. And so we want to bring to the table all the best cards so that whoever wants to consider such a program will also have all the necessary ingredients or tools so that the person or the hospital will be set up for a greater achievement. So this will be the outline. Briefly, we will consider the importance of clinical research, how we can get data, useful data from running a program like Survive to Thrive, and then who is even supposed to collect this data, and then we look at some possible research topics. So we consider research as a very tedious task. So most times when you even so over the past months, I've had the chance of asking some of my house officers, are you interested in research? And then you see the kind of faces they will make. So you ask why, and they will tell you they didn't enjoy their medical school kind of research. So I know across the various disciplines, people experience such displeasure. And so we see research to be very tedious. And mostly for projects like this, it's always an afterthought. However, everything that we do routinely, we are collecting data. So we just have to, right from the onset, set our minds to it so that we will be able to collect the right kind of data. So for the nurturing care framework, it has been endorsed by all our big organizations. However, there's still that significant evidence gap. So what works in the high middle income countries, we know contextually may not work in our settings. And even when you come to Ghana, we know there are some disparities intra-region. So we need to speak to our data, what is happening to our settings. That is what we need to bring to light, and those are the things that will inform policy or decision. So for most of us, just like Hope Exchange, we are either a district hospital, a tertiary hospital, or even a clinic. We are uniquely positioned to be able to impact or bring out this data. So at the facility level, the essence of getting good data, or what will be the impact of the data that we will take, this will serve as a quality improvement project. And so we'll be able to track clinical outcomes. So if we are saying we are now teaching mothers how to cook, how to play with their kids, and so what? But then if we are now saying that we have taught 10 mothers and this is what they are saying, then someone outside, someone in Cape Coast can also say, oh, then I can also do it. But then if we are just doing it for doing sake, then we are just going about our normal activities. And then when we take good data, or we set up to take good data, we'll be able to track these participants over time. So it's not just, we are not just dealing with the mothers, we are following a cohort. And so if we are able to track them well, keep good data, able to follow them up, then we can personalize their care plans. Because if you screen a child or a baby at maybe 3 months, and then you picked a developmental anomaly, however, you do not have their data or their contact information to follow up, then you've not really provided enough care for this child. Again, we know that we are resource constrained. And so if we are able to bring to bear some of the important areas in our clinical care, then we'll be able to allocate the little resources we have to areas that can make a maximal impact. And then also talking about the financial sustainability. I think Dr. Duma made a statement about the impact of the work that we are doing and the fact that preventive care or preventive health is not considered. It is so, and then one of the reason is that we don't bring out the numbers. You know, when we talk about HIV, we are talking about malaria. We are saying, oh, every 5 in 10 a child will die from this. So when someone hears this, the person is alarmed. But then for other, especially early childhood development issues, we don't speak to the data. We are either not doing it well or we are not doing it at all. So at the end of the day, no one would want to put money where there is nothing to show for. Okay, so those are some of the issues. And again, the last one is about research. As clinicians, we also have a mandate to do good quality research. And so it starts from having good data. At the national level, all these, if we take good data, it will be able to inform policy formulations and then advocacy. And again, we are on track, or we are looking at the SDGs. This information will feed into the national data, and then we'll tell whether or not we are lagging behind whatever indices we are doing. And then scaling up and replication. So what Hope Exchange is doing now, and then collecting data, Priscilla showed some of the skills and other things, proper documentation. So tomorrow or the next presentation, we will be speaking to numbers, telling you that we've screened 20 mother-baby pairs. We found this number of mothers that were depressed. So we have those data, and then we can be able to scale it up or replicate it at other settings. So who should be collecting the data? So first of all, to start the project, most of the variables that we will need, they are already routine care. However, it's just because we do not take them well. For instance, most times you get referrals, ABGA scores are not documented. So how do we follow these babies up? You get a referral. What was done at the referral site? Was the baby bagged? Was the baby just stimulated? We don't know. We just know that the baby is asphyxiated. So do we really know if the resuscitation at the pre-referral site is what is not going on well, or something happened in between the referral site and then the facility they were sending to? You get referral letters and there are so many blank spaces, but then we are the ones to collect these data. It is part of our routine work. So whatever we are doing, the antenatal data, all the book, the spaces, so far as we are seeing the mothers, we need to document it. So we know the common mantra in our work. Most times health workers, we use it, that what is not documented did not happen. And in other fields, law and then other fields, they also use that mantra. So if you've done a procedure, if you've seen a baby, a mother, and we don't document whatever we did, then it's difficult for whoever is reviewing the baby or the mother after you to be able to do or know what you did. So everyone in the hospital setting, especially the frontline clinical staff, we are all supposed to be collecting data. In fact, we are collecting it, but we are just saying or emphasizing that we need to collect complete data, and we need to, so the clinicians, it's not enough just saying so neurodevelopmental assessment, then you write no abnormalities detected, or mother history, mother has no concerns. At least write something so that later on, when this data is being reviewed retrospectively, what do you mean by mother has no concerns? So then how do you know So because mothers' knowledge about some of these things are not based on literature, most mothers, it's just based off their first child or previous children, or what the family is saying. So they compare kids. So we really need to know what they mean by no concerns. And all these things are what we are saying we need to document. Again, if we set out to do this project, considering the fact that data collection is not going to be an afterthought, then we need to get a research assistant. Most of our facilities, we get national service personnel. So you don't look far. It's not like you are going to get someone new to pay. So national service personnel, someone attached to the pediatric unit, can help or assist in taking this data, so that at least cross-checking on the completeness of the data will be very important. So briefly, just to round up, the various domains. So if we are thinking of some research questions, what are some of the topics that we can consider? So when we are talking about adequate nutrition, then you can consider the determinants of exclusive breastfeeding success and failure within the first 6 months of mothers enrolled in the program. So you start the program, most times you have a pre-program assessment, you know the mothers, their knowledge, their level of understanding and all that. Then at 6 months, you can assess this impact. So the breastfeeding initiation time, document all these things so that later when you need to take it, it becomes easier. Then also association between maternal nutrition status during pregnancy and neonatal birth outcomes. Because you have this cohort you are following, you'll be able to get these important information. And again, documentation, BMI. So we look at in our ANC books, all you can see is mother's weight. You don't get height. So later when you now want to make some of these or do some of these analysis, then you realize that you are missing an important variable. So all the work you've done over 5 years, you can't even talk about it because you missed a single important document. ABGA scores, most times we are not documenting. So how do we talk about some of these issues? So the next one, early opportunities for learning. We can consider looking at caregiver knowledge and practices regarding early childhood simulation. So I did a study in Kumasi looking at maternal knowledge on neurodevelopmental milestones. And then we found that most of the mothers had very low knowledge across all the 4 domains. And then when we asked them about where they were getting their information, it was from family and then friends. Healthcare workers, the percentage of mothers that were getting their information from healthcare workers were about 14%, which is very low. So when we do some of these KAP surveys, we'll be able to understand the challenges maybe mothers are saying. Probably we are talking to them, but they don't even understand what we are saying, because sometimes they come or we talk to them at a point when they are anxious about the health of their children, and also all the things that we talk about is difficult for them to appreciate it. Again, for the safety and security, we can also look at things like safe sleep practices among caregivers. So their knowledge practices and then factors that influence the adherence. So probably we've given the training or the teaching about some of these things, and then you can assess the impact, or even just across the cohorts, just look at what their knowledge is and then some of the things that they practice. The last one about health services, we can look at importantly just to inform our national health insurance and other policies, the cost effectiveness analysis of hospital-based nurturing care program. If we don't bring these figures out, it will be difficult for some of these interventions or projects to be recognized or to be considered as part of our national health insurance scheme. But then if we do proper cost effectiveness analysis, then the policymakers and then the those who are able to influence decisions will see that these things are beneficial, and so they may consider that. Again, so the data for such a project can be done in two ways, just as we do routine research. We can retrospectively review our charts, and then also we can set up right from the beginning to do a prospective data collection. So if we want to do a retrospective review, then that is where our quality data should be considered right from the beginning. Because if you spend 1 year, 2 years collecting data, and then after 1 year you want to review and you are missing like 20%, 30% of your variables, then you can't do a meaningful analysis with it. So in such a case, you may not need proper ethical clearance or an ethical review application. However, if you are considering doing a prospective study right from the beginning, then you need to organize your team, send out a proposal for ethical clearance. And in this case, Priscilla talked about consenting the mothers. That is just verbal. So in this case, then you have to do proper written informed consent. Okay, document these ones, have the copies down so that it can be used later on. So still talking about the essence of data, I'm part of a team that wants, like, we are doing some works in cystic fibrosis. We know it's rare in Ghana and most African countries. So we wanted to look at secondary analysis of data in US, UK, so African people with African descent, just pull out these data and see what is happening, because they've been collecting data for over 2 decades. And interestingly, what they tell us is that they have no documentation on race. So this is a registry that has been ongoing for over 2 decades. And then an important variable like just race, for you to do proper sub-analysis, you cannot get. So we pray that some of these things does not happen to us. So we need to know that some of the topics, or most of the topics that I talked about, is not just about academics. So it's not just because you want to publish or because you want to count papers. No, these are actionable topics. Most of them are QI projects. And so if you consider it right from the beginning, then the emphasis will not be on just counting papers, but making it even easier for people who will come after you to know what you have done. So like Priscilla, they have the documentation and all that. So she said, call me. So if you are calling her and she doesn't have all the numbers and all those things to talk about, then it becomes difficult or challenging. So it is very, very important that right from the onset, you need to consider that even if you think you do not have the capacity to do a full-blown research, or you don't consider yourself as an academician, just collect the quality data. And most of these ones are routine data, so that later in the next 5 years, someone comes to your facility and wants to write about whatever you've done. It becomes so easy for them to do. One last experience, so when I was doing my residency in Konfanochi, we started an adolescent support group for sickle cell. We had a lot of training programs and a whole lot of things done. Also, we started the transition from pediatrics to adults clinics, and then across the various specialties. Then recently, a group wants to do a project on transition in Tamale. And then one of the team members was like, oh, he has said the literature, he wants to know what has been done in Ghana about transition. So I was on the call, I was like, oh, we've done a lot of work in Kumasi, we did this. I was talking plenty. Then he was like, oh, but I said the literature, there's nothing like that. So I kept quiet, because all the work we did, we have no documentation. We all that we did were abstract presentations and all. And so now someone comes to start and it's like a new thing, but we've done all those things. Again, someone wants to start and the person has to now reinvent the wheel. that we've done it, but we did not document. So it's very important that as we are teaching the mothers, document the content of the teaching, the participants, how many of them are there, what were the topics for discussion, any key issues that came up. All these, keep a memo of all these things. And later, even if it's not a full-blown research, you can talk about your experience, write it out there, and then people can see that you have done an important work for these children. So thank you very much.
All right, Dr. Shayla, thank you so much. We are moving straight to questions and answer section. And then we are inviting Mr. Yensu and Eugenia to take us through. After that, we launch the program.
Okay. So before I proceed, I would like us to appreciate our speakers for this engaging and impactful presentation. Let's appreciate our speakers. Okay. So please, at this point, we would proceed to our question and answer section. And we have about a few minutes to do that. So we kindly request that if you have a question, you raise your hand or you type your question in the comment section, and then we would attend to it. And please, for the interest of time, please keep your questions brief and specific so that we can go through the questions as quick as possible. So we would take as many as time will allow us. We will take as many questions as time will allow us. So please, if you have a question, kindly comment for us or raise your hand and then we would attend to you. But in the meantime, we have a question from Dia, and she directed her question to Dr. Adomah. She is asking if children above 5 years are included in this program. So, Doc, please, you can answer this question for us.
Yes, thank you so much. So because we are looking at the first 1,000 days of life, we are actually looking up to the second birthday. And also because we know that mothers normally don't come after 2 years. And if the child is not sick, they will not come to the hospital. So because of that, we are limiting it to 2 years. We'll graduate them out at 2 years. If we get some who, when we talk to them, they're still willing to be coming for their checkups, as WHO, AAP, Ghana Health Service, all of us prefer, then we'll go through to 5 years. Why not? We're actually supposed to go through to about, I think, 21, throughout the whole of childhood till adolescence, till now we can hand them over to the adults. But we will see how it goes. Maybe when you are setting up yours, you can try the 5 years, and next time we are meeting, you can also share your experiences with us. Thank you.
Thank you to Dr. Adomah. And please, while we wait for you to comment or give your questions, and there's a very important information in the comment section, and then it is giving details about the CPD neurodevelopmental workshop that is scheduled for 26th and 27th February. So kindly take the details of the program. And we are waiting for any question or contribution. Kindly raise your hand and then we will attend to you.
Okay, do we have some questions anymore? Whilst we are waiting for some more questions, we have some beautiful audio for the mothers.
Hi, lovelies. My name is Mrs. Charity Osu, a mother of a 9-month-old baby girl whom I gave birth to at Hope Exchange Hospital. I must admit that 5 to 3 and their team has been a blessing to my entire family and my close relatives. We had the opportunity to meet with the physiotherapist and other professional doctors who assessed, guided us, and educated us on how to handle and take care of our babies, of which we paid nothing. On the food demonstration day, handmade toys training was made for us, the mothers. We learned new methods of making food for our babies. Nutritious food were made for our babies on that day, and we were guided on how to make them at home for our babies. We were also cautioned on some bad habits we practice at home, such as force feeding and others. This team also took it upon themselves to educate us on how to care for our babies to avoid illness or infections. Oh, I remember an audio that was made for us to guide us on how to bath our children, keep them safe and from infections whenever there is a change in the weather. This was a blessing to my family. We were also educated on how we breastfeeding mothers can boost our immune system to benefit our babies whilst breastfeeding them. My baby girl happens to be my second child. The glory of God, we've never, not once, been at a hospital. Unlike my first son, whom we were always visiting the hospital every month because he kept on being infected here and there. Indeed, I must say the knowledge which I paid nothing for has saved my family and other close relatives whom I always share things I learn with them. And also, it has helped me in my mother care business as well because I share everything that I learn here to some of my clients. Long live Hope Exchange, long live Survive Stay. God bless you all.
Thank you for the presentation. We have a question from Dr. Isabel and to our speakers. And she's asking if we can provide a cost implication for a program like Survive to Strive. And so please, over to.
Thank you, Dr. Sego Moses. So to be able to cut costs, and since it's not funded, what we've done is we are running on, running on existing structures. So for instance, it is more like an add-on to the child welfare clinic. So the public health nurse is already at the hospital anyway. So she coordinates the program. So it's not an additional responsibility, but that is her responsibility. The pediatric nurse specialist, the pediatrician, the medical officer, they will be on duty in the Survive clinic if it's a mega clinic for that day. So there are no cost implications at that side, at the side of man resource. Where cost implications come in are the lab tests, and then the ENT hearing assessment, the visual assessment, lab test. There are cost implications there. And it's about 500 to 800 cedis if they don't have insurance. I mean, it's not even on insurance. It doesn't really matter. So about 500 to 800 Ghana cedis, that the patients will have to pay out of pocket. A few costs are the cost for the cell phone that she uses to coordinate the groups, and then the credits that she uses to coordinate the groups. I will say that currently she actually has never asked for money to buy the credits. I don't know whether she has some friend at MTN who has been giving her the data for free, but she actually hasn't asked for credits to be running it. And we are looking that within this next year, we would rather have a devoted number. She will not use her personal number because sometimes things can get a bit intrusive. So those will be some costs. Physio should come at a cost because each one is a consultation. But what currently happens is that he normally comes with some, I think he's even on the call, he normally comes with some of his junior interns to come and then work with the children. So he also doesn't bill the children. But if you're going program-wise, you have a donor, a funder who wants to pay, then there are lots of places where if you could give people a bit of motivation, maybe it would be helpful. Thank you. Priscilla, I don't know if you have anything to add to it.
Please, the cost is normally on the food demonstration, and that one doesn't cost that much. Like I said earlier, we use locally available things. So let's say we are preparing pork, and we just buy condo, 5 cities condo, and but this one hospital accounts office do help us, and food demonstration normally don't cost that much.
Okay, so thank you, Priscilla, for your contribution. We have another question from Selassie, and she is asking, how do you include mothers without smartphones, hence cannot join the WhatsApp group? So if Sister Priscilla can also add her voice to this.
So with these mothers, when you get your data from the child welfare clinic and labor ward or maternity, you call them before you add them. You call them, you tell them we have this page, we want to add you. The mother will tell you. So these mothers, you group them. I have their own list, and periodically I do call them to ask how the baby is faring. And prior to a mega clinic, I call them to tell them that, let's say next week we're having a clinic, and a day before the clinic, I do also call them to alert them that they should bring their children to the hospital. So as I said earlier, it's a passion that we all need to develop before you can do the Survive to Thrive.
Thank you. So we'll still give ourselves about 30 seconds, and if there is no questions, we'll proceed to other sections.
Okay, thank you so much, Ms.
Um,
Junior.
Yes. Before we go, I think there is a last question here we can address. And Alberta is asking if we can advise on how to set up the clinic at the district level without a pediatrician or ENT service. So kindly address this question for us before we move on.
So, Alberta, the way Survive to Thrive is actually designed and the kind of tools that we use, they are such that they can be used at the lowest level. At the health center, at the TIPS compound, they can be used. For instance, the developmental assessment, Dr. Bru and her team will be coming to teach it at the end of the month. You can join in and then learn how it's done. We normally use the ages and stages, but I've even heard that there's a simpler one done by the Malawi team, which is even much simpler. Aside that, if you look in the records book, the mother and child combined records book, if you look at the very back, you realize that there are actually some developmental milestones listed there. I think 3 months, 6 months, 9 months, what the child is supposed to do. Under all 4 areas of gross motor, speech, hearing and language, fine motor and vision, and then social. So that is actually all catered there. So if you use that, if you don't have any other tool, and you're even just using that to assess, you will be able to pick up, this child is doing well, this child is not doing well, this child needs a referral. So there's actually a lot that you can do without having to have the pediatrician or the ENT service. There's a lot that you can do. So sometimes you even just ask the mother, when you mention the child's name, he tends to look at you. And those simple questions. And they are all in the combined records book. It's at the end. So sometimes we forget about it. We are just concerned with checking the weights and immunizations. But there's a lot of goodies in that book. At the back page is there. So you can run this program successfully, even without a pediatrician, even without an ENT or ophthalmologist. You can run it. And then when it gets to the time that the child is supposed to have those tests, then you can refer the child to get those tests done.
Thank you. I believe our time for question is up. And so if you have any question, kindly address it to the number we've provided in the comment section. So at this point, I'll hand over to the moderator to continue.
Sorry, Eugenia, just before you round up. So Pearl Peters, she's from the Ministry of Gender, Children and Social Protection. And she is saying that birth registration, safety and protection from violence and abuse should be included. The safety and protection is included. We didn't talk much about it, but during the anticipatory guidance, we do a lot of education about the child abuse, child safety in the home environment, because especially from 6 months onwards, when they're beginning to sit, now crawl and stuff, they pick up a lot of things. They cannot easily be abused. So all that education is done during the anticipatory guidance and is done during the mega clinics. And sometimes it's also done during the one-on-one. And as for the birth registration, they do it once they are exiting our hospital, they get it done. But I think that we just need to ensure that it's done. So now that you've mentioned it, we'll be actively looking out to see that it has been done. So thank you for that, Pearl. And Eugenia, one other thing.
Yes, please.
There are a few people that I just needed to mention. Josephine, a few people that I needed to mention and acknowledge. Otherwise, I will be transferred from this region to another region. So please,
I think we have a few minutes to do that. Yes, please.
Thank you. So we have Alexis, who is our colleague from Yale University on the call. Alexis, thank you so much for being able to attend. We also have Dr. Stephen Lai, the medical director of Cape Coast Teaching Hospital on the call. We have Dr. Yudia, the pediatrician at Hope Exchange Medical Center, also on the call. We had Dr. Jacqueline of Techiman Holy Family Hospital on the call. Marian Paga on the call. That's Onre. Yes, Onre Government Hospital. Thank you so much for attending. Dr. Marian, I'm expecting to see your Survive to Thrive clinic set up and running very soon. We also have Dr. Juliet Ejiso Hospital on the call. Thank you so much for attending. I saw Dr. Christy, the pediatric cardiologist, on the call. And then also Dr. James Dia, Deputy Director for CHAG, he was also on the call. Thank you also so much for attending. There are so many more people on the call that I should mention. I've not been able to. Barbara, pediatric palliative care specialist. Thank you so much for being on the call. There are a million others I'm supposed to mention, but time will not permit me to mention all. Sharon, UGMC, I came to you for breast milk banking, so I have to mention you. Otherwise, when I come again, you throw me out. So thank you so much for also attending. Josephine, over to you.
Yeah, it's now time to launch our program, the program Survivor to Thrive. We will call Dr. Isabella Segu Moses.
Okay, thank you very much. So it's my privilege to launch the program, and then I'll give my closing remarks as well. It's been a very rich afternoon. We want to thank again the team from Hope Exchange Medical Center. They've shared with us the objectives of the Survive to Thrive program. They've shared step by step how to set it up, what motivated them to do it, and how to set it up. They've gone further to share the tools that they've been using, the importance of data collection and research, They've even shared with us possible research topics. I believe that it's put everything together nicely for us, and we've had the opportunity to have our questions answered. And so for a program that has already been running for a little over a year, we are at a point where it's befitting to launch it. And it is my honor and privilege to declare the Hope Exchange Medical Center Survive and Thrive program duly launched. Thank you very much.
Wow. Thank you so much.
Okay, and
Thank
now
you.
I'll conclude quickly with my closing remarks. It's been a very successful program, I must say. I was looking at the participation, and at a point, I think I saw 100. I don't know if we went above 100, but we had participants from Ashanti region, various districts, but we also had participants from different regions, and I was able to count about 4 different regions being represented this afternoon. The discussions have been rich, the presentations have been very rich, and there are some key themes that we're running through. First of all, the emphasis on the fact that we really owe it to these children. It is their right to survive and to thrive. And it is all about giving them the best quality of life and the highest potential for them to move on in life. It is about timely support and early intervention, and about consistency right from preconception through pregnancy to the second year of life. It has to do with building relationships. There are various and several connections involved. There are caregivers, there are family members, there are communities, and then there are the health facilities and the health staff. If we would succeed, we really need to also pay attention to the caregivers. Their own health, and importantly, their mental health, is crucial for them to be in good standing, to be able to nurture the children in the right way. It's about consistent follow-up and communication. I was really impressed by the fact that we did not only rely on the social media communication, but we went further to address the needs of those who don't have the right telephones, smartphones, to follow them up with calls so that we could keep them in the loop. It is all about giving them the best quality of life. And I was also really touched by Adobe's story, funny though it was, the Hausa Koko and the Total. It's funny, but it really brings to the fore the strong message that it is not what we can see physically to do with a child's growth and development, but what we cannot see is even more important. And if we don't run a program that will bring to bear the thriving aspects, then we will miss out a lot. We've learned that breastfeeding and nutrition are very, very important in helping the children thrive. I also want to emphasize how important it is to make the program culturally sensitive and culturally appropriate. Otherwise, we'll be talking over people's heads. It will not be practical. All in all, I see passion. I see passion. There isn't so much about money, but when you are passionate, and I could feel the passion in the voices of all the speakers, and it's translated into what we are seeing now. So it's a call for a movement, a call for a revolution on how we measure health. And here I'm borrowing from Nana Hime's message. It's a call to refocus. I think that as health workers, we have the opportunity at every stage. We encounter the mothers before they get pregnant. We encounter them when they are pregnant, through their pregnancy, and after. We just have to lay a little emphasis on the getting up to the 2 years, and a little emphasis on putting quality into those contacts that we make with them, and being deliberate about making sure that whatever we can do to make the children move beyond survival to thriving, we will do it. And again, to borrow from Adome's quote earlier on, the child cannot wait. His name is today. Are we joining the movement? I hope that come a year from now, when we are hearing how much more Hope Exchange has moved forward with the Survive and Thrive program, we would also be hearing from other health facilities in Ashanti and in the other parts of the country about their own movements to make children survive and thrive better. And I can't wait to hear the interesting names that we'll give to these movements. Thank you all very much for cooperating. Thank you to all of the 63 of us who have stayed up till now. It's been a very, very fruitful afternoon. And I will say, let's keep the fire burning. Let's even fan it the more and be more passionate and deliberate in helping our children. Because after all, when it goes well, as a country and as individuals, grown-ups, we will all reap the benefits. Thank you very much, and may God bless us all.
Thank you so much, Madam Chair. The child cannot wait indeed. And of course, it is a movement. On this note, we would like to thank the Almighty God for such a wonderful program being launched. A special thanks goes to our Honorable Chair, Dr. Isabella, for steering the affairs of this program. Doug, we are grateful. How can I forget Nana Hima? Nana, we are so grateful. Thank you so much for your presence and the powerful message you gave us. Indeed, it is a movement. To our keynote speaker, Dr. Tricia, we say bravo. PSG, we are grateful. And to all facilities workers here and our proud mothers who are listening to us on YouTube, we say Ayiko to all of you. Let us all support this great cause for a better Ghana. Thank you all for coming. Without wasting much time, we'll take our closing prayer. And it's going to be done by Mr. Ofori.
Okay, thank you very much. Please, we are praying. In the name of the Father, and of the Son, and of the Holy Spirit. Alpha and Omega God, the beginning and the end God. This very afternoon, we thank you for everything. We thank you for a peaceful and a successful program. We pray that you will water every word that came to us, the knowledge that we have acquired and received this afternoon. We pray that may this project be visible and expand in nationwide. As we are about leaving to our various homes, we continue to pray for your guidance and protection upon our families and then everything that belongs to us. We pray and then we thank God for everything and then everything He's yet to do in our life. I pray that may God bless you and then may God keep you and may He make His face shine upon you. now and forever. Amen.
Amen. Thank you so much, Osofo. Thank you, everybody.
Thank you. Abnajo, I see you. Professor Pamela, I see you. Thank you so much for attending from the US.